from the starting of the session, you've seen the good video and everything is with the complicated, subluxated, hypermature, small page. This is more of a theoretical topic. It's a complete guide to cataract surgery, refractive surgery. Means we are facing LASIK and all that, and after that patient coming for the cataract surgery, what option we have? Requires meticulous planning. Especially challenging is the IOL power calculation, because there is a multiple time we have the errors in the power calculation. Previous refractive procedure can change the corneal profile, leading to challenges in measuring the eye optical power. And post-refractive surgery, patient may have irregular astigmatism, complicating the IOL selection. So intraocular IOL power calculation remains the most significant challenge. So it needs preoperative assessment. Refractive effect is related to corneal flattening, thinning, and several other evaluated these induced changes. Overcome all patient expectation and visual outcome. So it requires detailed history, understanding a type of refractive surgery, acute biometry. This is one of the most important thing. Use of device like optical biometry, Scheimpflug imaging, and high quality keratometry helps in appropriate IOL selection. Especially the wavefront analysis helps evaluate high order aberration, remaining high order aberration. Aim to provide comprehensive guide for accurate IOL power calculation, right IOL selection, intraoperative management, and especially the patient education about their expectation. So accurate IOL power depends on corneal refractive power and axial length. Now axial length remains the same, but cornea is becoming oblate in myopic correction and prolate in hyperablation. Consequently, changes in the anterior chamber depth and axial length changes the posterior corneal curvature and troubling the calculation of the intraocular lens power to be implanted in cases of cataract surgery. So preoperative planning, it is crucial to address the high expectation. There is need to emphasize the significance of understanding the managing postoperative astigmatism, patient counseling, complete workup, and treating the dry eye, because sometimes most patients with the LASIK, they have come with the dry eye, MGD, and topography and A scan changes assess the corneal curvature and higher order aberration, impact visual function. Repeated topography and A scan measures are taken. This gives the valuable information, including the equivalent K reading map. Topography also enables corneal astigmatism regular or irregular when dealing with irregular astigmatism. Compromise corneal optics to calculate the IOL power. First step entail topo-guided normalization and then calculation after 3-month period. In some cases where there is an corneal aberration is much more. Holiday 1, SRKT do excellent job in normal eye, but in post-refractive eyes they are inaccurate. Traditional IOL formula usually result in hyperopic surprises when applied to post-myopic correction, and in myopic surprises, one post-hyperopic correction done. So Dr. Hill and Shoy, that formula for those with prior refractive surgery is the Barrett-Drucke. Why there is a source of error? First and most importantly is the keratometric is the index error, because there is a change in the corneal curvature, and because of the change in posterior corneal curvature, and this leading to we got 7 minutes after our time. Okay? To calculate the dioptric focus power of the cornea, you need to know the both anterior and posterior. So you have to assess the depth of the anterior chamber and the corneal and change in the posterior corneal curvature. Let's give the formula. A new generation formula also utilizes the relationship between the steepness of the cornea and anterior chamber depth. After a myopic ablation, predict a falsely shallow anterior chamber depth and thus more anterior effective lens position. After hyperopic ablation, we can predict a false deeper effective lens position, resulting in an overestimated lens power with subsequent myopic surprise. So new techniques, what we can do, historical methods, what if you know nowadays we keep all the records of the doing LASIK patient. So pre-LASIK or pre-refractive surgery, keratometric, anterior chamber depth or epi-length. So if you know that you can assess with this, you're taking into consideration this, combining with the post-refractive surgery spherical equivalent. Double K method means utilize pre-refractive surgery keratometry and the what are the changes in the keratometric and calculating this. There is an ACRS online software available which give the predictable lens power. So AIOS2025 has a feature where we can select post-LASIK, post-PRK, post-RK in myopic or hyperopic mode. Barrett Uniscal 2 and Barrett 2K ACRS, and we usually prefer to do multiple formula in IOL power calculation and then select in between those. Aberrometry provide refractive information including spherical and cylindrical. Higher order aberration are considered abnormal and can be cause of increasing glare and halos after multifocal IOL. This may need treatment. Intraoperative aberrometry can be used, but probably it is not routine in the practice. There is a multiple option. Preferable lens is most preferred monofocal. Multifocal is advised to and usually when total higher order aberration to be less than 0.3 micron. EDOF IOL preferred due to lower chances of visual aberration. Teric IOL, we can use regular bow tie corneal astigmatism within central 3 mm. We can use toric. A difference of 0.75 in corneal astigmatism magnitude between two ocular biometer. In case of highly irregular astigmatism, it is best to plan monofocal and patient may later plan go topo-guided PRK, whichever is suitable. So in rule in practice, never place a multifocal IOL with previously hyperopic LASIK. Also never place monofocal IOL with a negative spherical aberration profile in eye with previous hyperopic LASIK. If patient had a myopic LASIK and smooth topography without any irregular astigmatism, sometimes EDOF or multifocal can be used. If there is irregular astigmatism or significant irregular topography, avoid diffractive technology and gravitate toward either monofocal. Now, this is video of the RK because in other cases, surgical parameters, surgical techniques remain the same. So this is a multiple eyes. When indoor, we have so many cases of RK. So we come across more of the type of these cases than anybody. So you have to select the right plane for the incision. It is not about the astigmatism. It is about the where the healthy cornea is more is available. So we have to see side port because then sometimes this incision give away. So once you try to do the 1.8 or 2 mm and the incision should be slightly posterior limbal so that you can avoid that end of the incision of the RK incision. So once micro incisional forceps, then you can remove this and put the intraocular lens. Another is the same with the femto you can do with the same. Removing, again the incision is the most important thing. You can select the site. So here the selection of the incision site is most important, taking into consideration post-limbal incision, low phaco, low bottle height, because they are the myopic patients, and we can. Then AIOL2025 felt okay, you have to use the keratometry different, and you can assess the level of operative concentration, and then use of the eye trace. In the post-operative eye trace, what happens, what it do? If there is a brulling and a change in the reflection, we thought of that there is a regression of the myopia. But if the DLI is less, it is means it is an starting of the cataract and you can directly go for the cataract surgery. So in short, enhanced monitoring, addressing, and careful consideration of corneal shape, visual expectation, advanced diagnostics tool give a good surgical outcome in difficult situation like RK and LASIK patient. Thank you. Thank you.